I appreciate this opportunity. As mentioned by Danielle, this is kind of a two-part talk. The first part is kind of going over the common obstetric disorders and regroup for talk number 2, which is kind of more of a, chronic medical conditions and how pregnancy can complicate that, leading to critical illness. So I certainly don't pretend to be an expert in this area, but just working in critical care and having worked at Lakeside Hospital and Bergen Mercy Hospital, and then having been a critical care medicine program director where I had to teach fellows. I have spoken on this before. I've managed these patients in the ICU. So, I know enough to be dangerous, if you will. I'm going to tell you that both of these talks are very highly weighted on 2 really well-written review articles from our top journal in critical care called CHEST. And so, again, there's kind of a part 1 and a part 2. So that is the bulk of where this came from. But I've added some stuff from our FCCS course, Fundamental Critical Care Support. There is 1 lecture on obstetric emergencies in there. So I weaved in a little bit of that information and then just some other resources. But very heavily weighted on these. And I'll tell you, it's a little older, 2015 are these references, but not a whole lot has changed. And they're really, really good. So if you're looking, to kind of go back and read something, both of these references are in the talks. So for the first part, obstetric emergencies, first we have to kind of talk about the normal physiologic changes of pregnancy. These authors kind of give a recommended approach, a 5-step approach to critical care in pregnancy that I find kind of helpful. So I'll take you through that. And then we will talk about the most common obstetric disorders like preeclampsia and eclampsia and HELPS and a few other more rare births. But we will kind of talk through all of those as we go. So, we in critical care, intensivists, but certainly our nurses, need to be familiar with the very unique differences that come along with having a pregnant patient in the ICU. I kind of always joke, I've been doing this 15 years, and I kind of joke saying that, and I think this is true, the only 2 things that scare me anymore are pregnant moms and blue babies. I don't want to have anything to do with either, and you guys do this on a daily basis. So, God bless you. But, I think everybody, and I don't know, Dee, you've been doing this a while. I imagine the hair on your head stands up straight a little bit, at least, when we get a pregnant patient in the ICU.
That's what they call me.
Clearly, things are different in pregnancy. Medical disorders present differently in pregnancy. And the normal ranges of vital signs, or at least normal for us, are very different in pregnant moms. So we got to talk about all these physiologic changes. Unfortunately, our approach is sometimes different because we can't use some of the diagnostic tests or some of the medications we would like to because of potential damage to baby. And then some of the physiologic targets that are, commonplace for us in the ICU, like a CO2 of 40 or a PaO2 of 60 on blood gases, just being examples, have to be modified in pregnant moms, as we will talk about. So, there's a fair amount of difference in managing these patients. So, when we're talking about obstetric patients, we're talking about women who are admitted to the ICU either during pregnancy or by definition within 6 weeks after birth or the unfortunate termination of their pregnancy, because there are things like, cardiomyopathy being an example that are postpartum conditions, but still related to the pregnancy. So by definition, within 6 weeks after again, pregnancy. Fortunately, we're getting a little bit better at this. This may be a little bit older data, but if you look at mortality rates in pregnant moms, several years ago, back to 1990, compared to just 10 years ago, there has been a significant improvement. But you can see, unfortunate, 230 deaths per 100,000 pregnancies in developing countries, that is, still too high. I would argue 16 out of 1,000 in the United States is still too high. But as we'll talk about, there are unforeseen obstetric complications that, come with very high mortality rates. So more to come on that. So now we're going to kind of talk about the physiologic changes that occur during pregnancy. There are very significant cardiovascular changes that tend to occur, with particular change in blood pressure. So a decline in blood pressure is a normal part of pregnancy. Hypertension, particularly early in pregnancy, is not common. Hypotension is. So if we have, a mom who's developing hypertension, that should get our attention. So blood pressure normally decreases, reaches a nadir at 28 weeks, and then gradually increases to normal at term. But again, hypertension is not a normal physiologic change. Now, changing cardiac output, on the other hand, absolutely is, for several changes or several reasons that we're going to talk about. I mean, there can be upwards of a 50% increase in cardiac output, particularly in that second trimester. And that has obvious implications in moms who have underlying cardiac disorders like valvular disorders, or certainly pulmonary hypertension being, very fearsome with pregnancy, as we'll talk about in the second half of the talk. As mom's uterus is expanding with this baby in there, compressing the IVC, this obviously has cardiovascular impact as well, particularly if mom's trying to lay supine. And so we need to think about this in the ICU when we've got a patient and use pelvic wedges and these sorts of things to get the baby off of the aortocable region to prevent the compression that is dropping the preload, that is reducing the cardiac output. So again, significant cardiovascular changes. And I guess I already kind of mentioned that, pregnant patients in the ICU, especially in more advanced stages of pregnancy, need to be positioned appropriately to help protect baby and to ensure adequate, blood and oxygen delivery. So cardiac output changes primarily because of the changes in the intravascular volume. The plasma volume increases dramatically, like 50% by term. And while the red blood cell mass increases as well, it is less. And as such, there is a physiologic anemia that occurs with pregnancy. Now, in some ways, this is beneficial because, as we'll talk about, there is increased hypercoagulability with pregnancy. And so, this relative anemia decreases the viscosity of blood, promoting flow and helping to prevent clots. The other benefit to this is, blood loss during pregnancy is not, or during delivery, I should say, is not uncommon, upwards of 500 to 1,000 mLs. And if we've got a, significantly distended volume of serum, that, delivery and that blood loss is less detrimental to mom. But, things can occur leading to abnormal hemoconcentration, like, hyperemesis leading to dehydration, preeclampsia, and some of the physiologic changes that occur there that we're going to talk about, that, kind of alter what we just talked about and, have hemodynamic effects, particularly in the setting of hemorrhage. And this can put the placenta at risk, and this can also increase chances of clots. Love my pulmonary physiology for obvious reasons, and so it's important to note that increased minute ventilation is a normal physiologic change of pregnancy. And this is hormonal and specifically related to progesterone, but this increases tidal volume. And so, moms, they'll compensate if they normally have a respiratory alkalosis. They blow down their CO2. So a normal CO2 for a mother is 30, where most of us think about a CO2 of 40 being normal in the ICU. And this has significant implications when we're talking about managing, asthma or certainly ARDS in the ICU and our approach to those patients, because as it turns out, the uterus and the baby don't like elevated CO2 very much, and we'll talk about that. And so 40 is actually elevated in a pregnant mom, and we need to be mindful of that as we're managing these patients in the ICU. With the expanding pelvis and upward, kind of pushing up of the diaphragm, there is a significant change in the FRC. And so, mom can't take the normal deep breaths. The functional residual volume is decreased, increasing atelectasis and reducing the oxygen reserve in moms. So, under normal states, they're not hypoxic, but they have less reserve. So if they aspirate or some other pulmonary insult occurs, they have less reserve. They're going to plummet their O2 faster than, in a non-pregnant state. So that needs to be thought. There's also changes in GFR. We talked about, the increasing circulating volume. As a result, the GFR increases by 50%, and the creatinine actually goes down. So, 0.8 to 1, well, let me say this differently. Anything above like 0.8 to 1 actually represents acute kidney injury. So, there are changes there that need to be thought about. And this increased GFR also has implications for renally cleared drugs. So something that's renally cleared, and dosing is important for, the pharmacokinetics and pharmacodynamics. This needs to be thought about, and we may need to change the dose of drugs in this setting because of this physiologic change. And then lastly, but really important for us in the ICU in a mom that may need to be intubated, there's a variety of different changes that occur that put moms at risk for aspiration. And so, oftentimes in the ICU, I'll say all the time, all of our intubations go super smoothly. There's never complications, never an aspiration event. But this is that's a sarcasm. They almost always go sideways. But they're more likely to go sideways in a pregnant mother because gastric emptying is delayed. There is a relaxation of the esophageal sphincter. And that again is hormonally mediated, but also all of this, pelvic pressure on the stomach, and again, delayed gastric emptying. And it's like a perfect storm. So moms who seize, moms with altered mental status, moms with respiratory failure that need to be intubated are at very high risk of aspirating. And pregnant moms, by definition, are a difficult airway. And that's something we need to be thoughtful of, not only because of this, but because of all the swelling in the soft tissue of the oropharynx that comes with pregnancy. So they often need a smaller endotracheal tube as well. And all of this needs to be thought about as we're, emergently intubating your patient. So again, we get a little nervous in the ICU with pregnant moms for good reasons. We talked about, changes with cardiac output, but uterine contractions, add to the cardiac output. So that big muscle's contracting, and, an already increased cardiac output is going up further. And so, this also can have very significant hemodynamic consequences, particularly if there are cardiac, vascular, or valvular abnormalities. And then, of course, there's shifting of blood, loss of blood volume that occurs with delivery of baby and loss of contents, but certainly during delivery of the placenta. And, anxiety and pain and, the positioning of mom and any Valsalva events that occur during the labor process also obviously has implications in cardiac. Leukocytosis is common in pregnancy. Obviously, we have a high index of suspicion for sepsis in pregnancy, one of the big three causes for ICU admission, and a very high cause of maternal death during pregnancy, as we'll talk about. But unfortunately, leukocytosis is not uncommon as a physiological change. So we need to consider that, but also consider the patient in front of us and whether or not they're in early sepsis, and that's part of what's going on. And I probably should have switched this here, but we talked about delayed gastric emptying, and this is even further delayed during labor, again, putting mom at risk for aspiration, and a mom that's already working very hard and has diaphragmatic fatigue from the whole labor process. And then if she aspirates and she's tachypnic, mom's going to plummet pretty quickly. And keep in mind, she's got atelectasis as well. And so again, limited oxygen reserve and all of this going on. And you can see how these normal physiologic changes may lead to rapid decline in a pregnant mom in extremis.
So how soon after delivery do a lot of these changes?
Probably a better question for an OB, to be really honest with you. And I think it kind of depends in terms of what we're thinking about. I mean, the rate of change of the hormonal aspects is going to be different than the rate of change of the plasma volume, the cardiac output, and all of this. So I really kind of think it depends upon kind of which aspect we're talking about. For our OBs on, what's Emily's last name? Lang. Dr. Lang, you got anything to add to that?
No, I would agree with you. I think that it depends on, which thing you're looking at. Like your leukocytosis is only going to last for a week or two from that standpoint. Your hemoconcentration or dilution, almost resolves as soon as the baby delivers because it's that initial bleeding from that standpoint. Your gastric emptying is a lot of times truly a physiologic thing of just the gravid uterus. And so once that's gone, then you can process everything normally. So I think it really makes a difference, which condition has put them in the ICU and under critical care. But I also think that the cardiac things, which is really what we're looking at really what winds up on your doorstep, that really is that 6-week postpartum window. So we need to be aware of that for a much longer time.
I guess that was probably more my question about the cardiac stuff. Because we're trying to understand these patients that could come to us, like what are we expecting? I mean, differences we would expect.
Yeah. Dr. Lang, anything else to add on sort of the physiologic changes of pregnancy? Anything else we need to be mindful of in these patients?
Well, I mean, I know you're going to get to preeclampsia, but preeclampsia is the thing that comes to mind is like, okay, you have a person who's hypertensive and they're 5 weeks out from delivery. Is this just a normal hypertensive patient? And it probably is not. And we actually had this patient probably about 2 years ago. She was being managed by urology for fluid overload on the 2nd floor. And someone finally was like, hey, can you come down and chat with her about a breast pump? And I was like, took one look at her chart and I'm like, this is preeclampsia, like 100%. Got her upstairs, gave her mag, she diuresed, she was perfect. And it was like, oh, we didn't even think about that. And it's like, okay, which is okay. And she was getting good care in the sense of like supportive care, but they were doing Lasix. They weren't aware of they weren't paying attention to her oncotic changes. They were doing nothing from a seizure prophylaxis standpoint. And it was, just postpartum preeclampsia.
Yeah. Yes, and we're going to do a lot of talking about preeclampsia, severe preeclampsia, and eclampsia here coming up very, very shortly. So we kind of went through the normal physiology. Now we're going to talk about, the causes of critical illness in pregnancy. Because unfortunately, these patients, can become critically ill, requiring ICU admission for organ dysfunction. And some of these are direct, obstetric complications. And then some of these are, medical disorders complicated by pregnancy. Or let's face it, pregnant moms are patients too. And so trauma ensues, or, an overdose, or just an infection that any of us could have gotten, and they happen to be pregnant. So there's kind of 3 buckets here that need to be thought about as we're going to be talking about them. But it's important to really think about what is is this a direct obstetric complication? Because as we'll talk about, the approach to that patient is very different from, or can be very different from, a patient who has an underlying medical problem and they have physiologic changes that may mimic, the preeclampsia, but it's not preeclampsia or eclampsia. In that setting, delivery is what's going to, solve the problem, if you will. But if it's a underlying medical problem and changes of physiology from the normal changes of pregnancy, delivery may not solve the problem, and there's more direct ways of treating those patients, and we're going to kind of talk about that in the second half. But the most common obstetric complications that bring a patient to the ICU are hypertensive disorders, hemorrhage, and then kind of more, well, number 3 is infection. Those are the big 3. But then, there's more ominous things like amniotic fluid embolism. And, just sort of the complications that can occur from anesthetics, or certainly, surgical complications, particularly with C-section. So many of these things, can occur directly related to OB. And then, of course, there's the indirect causes, which I've already alluded to. But the majority of the disorders that bring a patient to the ICU are direct obstetric complications. So it is important for us to think about these. And again, as already alluded to, preeclampsia, obstetric hemorrhage, and pelvic sepsis make up the vast majority of the patients that may come to us, in the pregnant time frame. So, the most common sort of non-obstructive things are asthma, community-acquired pneumonia. Again, sepsis is common, particularly UTIs and other genital ureteral infections, as we'll talk about. Clots, we talked about, hypercoagulability, and so DVTs and PEs certainly bring pregnant moms to the ICU. And I kind of talked about trauma, and, unfortunately, pregnant moms are under a lot of stress, and otherwise, and unfortunately, drug abuse and drug overdoses and some of these types of things obviously ensue as well. It's reported that about 50% of the ICU admissions occur during labor or in the first 24 hours after delivery, with a smaller number, being antepartum and a very small number being postpartum. But if you look at the, associated mortality, the majority of the mortality occurs in the postpartum state. And I think part of that, again, is because we're looking at obstetric complications, and part of, the treatment may be delivery. And these are high-risk patients that even though we do deliver and we save baby, mom can have downstream complications that may lead to a mortality. This is a really, really busy slide. Again, I'll provide these resources for you, but there are some nice tables in here that kind of give a more comprehensive view of, a larger number of systemic things or obstetric complications that may bring a patient to the ICU. So a very comprehensive list of, complications of pregnancy, of underlying chronic conditions that can lead to ICU admission as a complication of the physiologic changes of pregnancy. And then again, some things that are completely unrelated to pregnancy that can ultimately bring a pregnant mom to the ICU. So I kind of alluded to those 3 buckets, and this table kind of more clearly lists some of those complications. This is a table that kind of looked at a resource and said, well, what we said, hemorrhage, hypertensive disorders, and sepsis would be the 3 most common things bringing the patient to the ICU. In the order, at least in this case series, it was hypertensive disorders, hemorrhage being number 2, and then pelvic sepsis being number 3. But those would be the big things to think about. So I mentioned that these authors kind of talk about a 5-step approach to critical care in pregnancy. And I think this is really kind of a nice way of systematically looking at your patient who's just arrived to the ICU. And we're kind of doing that workup to sort out kind of what's going on. Is this obstetric related? Is this just a physiologic change? Because again, as we'll talk about very soon here, the management may be different. How sick is mom? Is this single organ failure or is this multiple organ failure? Because, in the increased risk of morbidity and mortality is associated with the larger number of organ systems involved, and we'll talk about the most common ones. Is mom or baby at risk if we continue with this pregnancy? And if so, do we need to think about delivery? And then if delivery needs to be hastened, how are we going to do it? Is this a C-section? Can we try and do a vaginal delivery? Is this going to involve general anesthesia? What is the approach going to be? And then, what needs to be done to optimize mom prior to delivery. So those are kind of, in general forms, the 5 steps, but let's go through this a little bit more carefully. So step 1, is this a medical or obstetric disorder? Here's another table listing a number of different syndromes that moms frequently present to in the ICU, with a nice table looking at the obstetric causes of things like, thrombocytopenia and coagulopathy, and seizures versus the medical causes. And, again, it's important for us to look at this and think about this. Now, there's some funny things on this table. Fever, is it preeclampsia or is it dengue fever? Well, I can't remember the last case of dengue fever I had, but, this is sort of an international thing. So, internationally, that's a fairly common cause of fever in the pregnant patient. Malaria is listed on here. So kind of some funny things. But nonetheless, I think it makes the point of saying, whatever the list of, lab abnormalities or, other physiologic findings that is bringing mom to the ICU, we need to think about, is this more likely to be an obstetric complication with, again, preeclampsia, and eclampsia being very, very common, and then of course HELLP syndrome, or, and we're going to talk about all of these, and we're going to talk about the differential diagnosis that may present similarly to preeclampsia, eclampsia, and HELLP syndrome. But it's important for us to distinguish which is which, because HELLP syndrome certainly, and eclampsia, we're likely going to prepare mom for an early delivery, depending upon how far she is and how sick she is. But, that medical condition that is mimicking, perhaps, delivery isn't going to do a thing and we're just delivering prematurely a baby and some of the downstream effects that may come with that. So kind of a helpful table there. Next, is there failure of multiple organ systems? So, the organ systems that are most commonly involved in pregnancy, in the ICU, certainly renal failure. But, in the ICU, the most common cause of renal failure is ATN. So hypotension and poor blood flow to the kidneys that leads to acute tubular necrosis. But in a pregnant mom, it's actually acute cortical necrosis related to thrombosis. So whole portions of kidneys are, basically necrotic from getting inadequate flow from clots, particularly associated with complications like DIC. And so, that's a bigger hit to the kidneys than ATN. They usually gets better in, 4 or 5, 7 days in the ICU. And so this needs to be thought about and is managed differently. I kind of alluded to DIC, a not uncommon complication of many of the presenting syndromes in the ICU, and certainly thrombocytopenia as well, being part of the hallmark definition of HELLP syndrome. So we need to be mindful of that, looking for this on our labs, drawing, coags and doing a DIC workup in our sick moms that get moved to the ICU, because these are common multi-system, multi-organ failures that can happen in the ICU. When it comes to looking at mom and baby and how sick, it's an unfortunate reality that maternal survival takes precedence over fetal survival. Obviously, we're monitoring both very closely. We've got one of you at the ICU keeping a close eye on baby through fetal monitoring. We're keeping a close eye on mom. We're having a good conversation along the way, and we're, making a decision on what needs to be done. But the unfortunate reality is we have to have a primary focus on mom through all of this. We talked about C-section versus vaginal, and at least vaginal birth. In this report, it stated that about 70% of patients in the ICU, as you might expect, will go to delivery by C-section. And the approach with regional versus general anesthesia, and I might ask for some input here because I'm not in the OR very often. I'm just kind of waiting on the other side. But I'd be curious from Dr. Lang, in your experience, regional versus general anesthesia and how you make that decision?
Well, we prefer regional if possible, mostly from a social standpoint, or that maternal bonding and things from that standpoint, but not always. I mean, I think that we want to make sure that we're getting good analgesia for the patient, and sometimes that's not able to. And also hemodynamically, sometimes a spinal is going to be not as easy to control, and if they're under general, we can do a lot more. Give pressors, give hypertensive meds, whatever we need to IV wise. So I think that, yes, kind of knee-jerk reaction is to go with the spinal, but sometimes we do request a general.
Yeah, so that's kind of what I was thinking, but I really appreciate your insights there. And, again, we've got mom. A decision is made, okay, we need to go for urgent delivery. We got to do things to prepare mom. And again, sometimes DIC is present, certainly thrombocytopenia is present, and we need to think about correcting those things prior to the C-section. What's recommended is a fibrinogen greater than 100, platelet count greater than 50, but if we're going to be working around the spinal cord, we need a little higher platelet count as listed there. All right, so now we're going to start talking about the conditions unique to pregnancy, with a heavy emphasis on the common things. But with some of the developments over the last decade or so, there's some newer problems. And I'd love Dr. Lang's comment on, for example, VBACs. Moms who have had a C-section and they want to have a vaginal birth, and they've got a scar, and this can lead to prominent adherence of the placenta and placentation, and we'll talk more about that as we start talking about risks of hemorrhage. But with this kind of change in recent times, that then can lead to complications with delivery and risk of bleeding. There are more and more fetal surgical interventions being done with, some of the very early testing that is done, finding congenital abnormalities in our babies. And, these surgeries are, potentially leading to complications of pregnancy down the road. And so this is kind of a novel thing that needs to be thought about, as well as ovarian hyperstimulation syndrome. Because, there's a lot of, infertility ongoing these days, and hormonal changes and things like this that have a significant impact on ovaries, promoting, pregnancy, but impacting the ovaries through the pregnancy all the way up to delivery. And ovarian hyperstimulation syndrome is becoming more common as well. Any comments on those, Dr. Lang?
No, not really. I think that's good. Yeah.
Okay. All right. Those are rarer things, but just being comprehensive. All right. So now we get into the common things. I mean, the real meat of the talk here: hypertensive emergencies and preeclampsia. So, again, this is a very common cause of admission to the ICU. The exact cause of this is unknown, and maybe Dr. Lang has more knowledge on this, but it's thought to be related to the placenta and, some of the hormones and cytokines and other things that a placenta being present in a uterus cause. And, there's a direct association between delivery, removal of the placenta, and improvement in hypertension after delivery. So again, the mechanisms are not fully clear, but delivering that placenta seems to alleviate the hypertension of preeclampsia and eclampsia. This seemed a little high to me, and I'd love your guys' viewpoint on this. They report that preeclampsia can complicate 10% of pregnancies. Do you guys see it that often? Yeah, I'm seeing some nods. Dr. Lang, it seems high to me, but.
No, I would say that that's probably correct. We probably don't diagnose quite as much here, partly because of our patient population. We ship a lot of these patients over to women's, but then also, just the diagnosis criteria. You could either hold it really strictly, or you could, I guess more conservative versus liberal diagnoses. But yes, 10 to 15% of all pregnancies.
Yeah, wow. Just being that high, I would think we would see a few more of them or get called for a few more of these. You guys must be pretty comfortable and, doing a fantastic job of managing these patients. Because, these patients, particularly those who develop severe preeclampsia with, end organ damage as a result of the preeclampsia, are at high risk of developing multi-organ failure, and certainly moving on into eclampsia complicated by seizures. And, eclampsia is the furthest end of the hypertensive spectrum of this condition, and, can occur before, during, or even after labor. I think that's more rare, but nonetheless can occur at any point. These patients often present with some subtle visual changes. Headaches are very common. They often have upper abdominal pain, particularly in the right upper quadrant, and they can develop spontaneous bruising, which is a not uncommon, flag of pathology, and, clearly something's going on. If it's unclear as to exactly what's going on, checking a uric acid level, it can help to kind of tease out, what's driving the hypertension. But, we need to do a pretty extensive lab workup in these patients, as already alluded to see what that platelet count is, to see if they're hemolyzing as represented by schistocytes in the blood. Again, the creatinine should be low by normal physiology. If it's increased, that's a marker of organ failure. And then LFTs, as we're thinking about HELP syndrome, or perhaps the liver just sort of being an innocent bystander during a period of acute critical care illness. And, unfortunately, severe preeclampsia, eclampsia, not infrequently as an indication for urgent delivery once mom is stable. And so this table kind of goes over, the majority of the manifestations of preeclampsia and eclampsia. So manifestation on the left and the clinical significance that comes with this over on the right. So proteinuria and elevated creatinine, very common with this syndrome. As already alluded to, abdominal pain, particularly right upper quadrant or epigastric abdominal pain, and LFT abnormalities. We talked about spontaneous bruising, obviously bleeding like epistaxis, and abnormalities in the coags that we draw on these patients. Herald DIC and other hematologic failure as a complication of this syndrome as well. Visual symptoms, again, not uncommon as part of preeclampsia and eclampsia, and it may just be part of the syndrome, but it may indicate, a neurologic complication associated with this. So they're hypertensive and, acutely they're having visual changes. That may be a marker of intracerebral hemorrhage or other stroke as a complication of what's going on. Certainly seizures, are one of the primary things that we're on the lookout for. And certainly thinking about this as a marker of, transition from preeclampsia to eclampsia, and hopefully they're on magnesium to help try to prevent this. But we have to be mindful that other things can cause seizures as well. So is there a metabolic abnormality that may be contributing to this? Did they overdose on something known to cause seizures? Or do they have an underlying seizure disorder? And, late in pregnancy, again, there are changes in pharmacokinetics, and perhaps their level is, physiologically low, leading to a seizure. So we kind of have to think about all of these things and what's going on in terms of, is this certainly part of the preeclampsia, eclampsia syndrome and progression thereof, or is there something else more medical going on? Got to be mindful of the severe hypertension and obviously managing the severe hypertension, and more to come up on that. But a patient in shock, is an indicator that something else is going on. Again, this is an hypertensive syndrome. So if a patient's in shock, they're bleeding. Something is, likely bleeding. They could be septic as well, but we've got to be thoughtful about, hemorrhaging or liver rupture, those sorts of things to contribute to their shock. And then, pulmonary edema can occur through all of this. They're hypertensive, that's increasing their afterload. They already have an increased cardiac output. They're on tocolytics, not infrequently as well. Put all of that together, and pulmonary edema is a risk. And then, of course, mimicking pulmonary edema may be ARDS, and we see a fair amount of ARDS. And I've already alluded to the fact that moms are at high risk of aspiration, and that's a not uncommon cause of a chemical pneumonitis in the lung that can lead to ARDS. And I'll make a few more comments about that in upcoming slides. So in terms of treating the hypertension, there's a variety of different parenteral antihypertensives, and I got a chart on the next slide that kind of goes over there. Here, these, moms are at high risk for needing to deliver early, and we need to be thoughtful about that. And you guys know way more than I do about this with regards to the antenatal corticosteroids that need to be given to promote fetal lung maturity during that, 24 to 36 week gestational age. These patients can change and deteriorate rapidly, so we need to keep an eye on their lab tests quite closely, upwards of every 4 to 6 hours. And again, we've got one of you in the ICU helping to monitor baby, and frequent fetal ultrasounds are being performed, and we're just kind of keeping a very close eye on baby through all of this. And that's a nerve-wracking situation for us to be in, but it is a reality. And of course, we need to be mindful of complications with the placenta, like placental abruption, that can occur and rapidly lead to fetal compromise if not picked up on very early. This is kind of a comprehensive list of drugs that can be used to treat the hypertension in these patients. We like our Cardine in the ICU, so I think that'd be the most common thing that we would use. It's just something that we can titrate, and we can avoid the spikes. Labetalol and hydralazine are IV push drugs that we can use, and those, are helpful to bring it down, but unfortunately there can be, spikes up and down in blood pressure. And it's those spikes that can lead to CNS complications, either hemorrhagic stroke by that upward strike, or encephalopathy when we've kind of dropped the blood pressure too much and mom's not getting enough blood flow to the brain, putting that penumbra at risk. And so, having something that we can titrate very closely. I'd have an art line in this patient as well. So we're monitoring the blood pressure very closely, and we're avoiding the spikes upward or downward in blood pressure to avoid complications while we're managing the blood pressure. In terms of other management, obviously we're trying to avoid seizures, but that is part of the syndrome of eclampsia. And if they occur, we've got to have very strong focus on airway, because again, these patients are at very high risk of aspiration. We need to be very mindful of oxygenation and ventilation. I've already said, pregnant moms have a low oxygen reserve, and they have a low physiologic CO2, and baby does not do well with hypercapnia. And so seizure, they're hypoventilating. We gave them Ativan to break their seizure. That causes further hypoventilation, and hypercapnia occurs. And so we need to be looking for that. Obviously, I alluded to benzodiazepines to break the seizure, and then control the hypertension. You guys have way more experience than we do with the really high doses of magnesium sulfate that these patients need in terms of, preventing and treating seizures, upwards of like 4 to 6 grams over 15 minutes, and then a continuous infusion, and, potentially keeping an eye on the therapeutic levels. Dr. Lang, can you educate me a little bit, or you add on to the group here your approach to mag sulfate in these patients?
Yeah, usually we do a 4-gram bolus and then 2 grams per hour, and we check magnesium every 6 hours, but I'm doing like 2-hour mag checks clinically to see if they'll have reflexes. That kind of helpful?
Yeah, and what kind of things do you tell the nurses to be, kind of watching for physiologically, or, on physical exam to make sure that they're not getting toxic from mag?
Yeah, I think we're, really oftentimes focused on reflexes, like do they have clonus or do they have absolutely no responses left?
Right, yeah, exactly. I mean, that's probably the best, or, the hyporeflexia. But this causes hypoventilation and, altered mental status and all of these sorts of things. So these are, in addition to checking levels, obviously we need to be keeping a close eye on our patients in avoiding mag toxicity. If it's refractory to magnesium, again, benzodiazepines, Keppra, we love our Keppra, fosphenytoin is another opportunity for refractory seizures. Obviously, fetal decompensation can occur with, fetal bradycardia or other signs of placental insufficiency. And, fortunately, this usually gets better with resolution of the seizure, but that's putting baby under a lot of stress, and we need to keep a close eye on baby while we're also keeping a close eye on mom. Keep in mind that after the seizure, mom is going to be pretty sedentary and minimally responsive, and we want to probably place her in the left lateral decipitous position to keep baby off the IVC. And, complications such as placental abruption can occur as a complication of a seizure associated with eclampsia, and we need to be very mindful of that and capture that early. So questions, comments, again, this is probably the most common thing that we're going to see. We're not going to see HELP often, or at least hopefully we're not going to see HELP very often. Anything to add on preeclampsia or eclampsia?
I guess I'd also just add in there, oh, sorry.
No, please, go ahead.
Okay, urine output, I think that, we talk about it a lot, but sometimes we forget to remind the nurses that magnesium is renally cleared. So if they have no urine output, then their mag levels are going to be very high. We want them to diurese because that would be the most physiologic thing to happen after delivery, but sometimes it's not. So getting, because, patients will give pushback, like, do I have to have a Foley? I peed, but I didn't catch it in the hat, and so we really, really want accurate I's and O's.
Yeah, thank you. That's an important pearl. You were gonna make a comment?
Just a question, with the smaller, the physiological changes, vent settings, will those look majorly different? And then if you do like you do deliver,
Yeah.
then do we change those immediately to more of a usual setting, or do we is it a?
Yeah, no, those are great questions. We're going to talk about vent settings when we talk about ARDS, but just in general, because we'll talk about it a couple of times, in general, we would need to target a little higher PaO2. So a lot of times we're happy with 60. In this setting, we want to target a PaO2 of at least 70 to make sure that baby's getting adequate oxygen delivery. And then as alluded to, CO2 is important, and CO2 is important in seizures too, by the way. I mean, you know, hypercapnia can lower the seizure threshold. And so we've got to be mindful, mom's normal CO2 is 30, and mom is normally hyperventilating. So setting the vent at 12 is not appropriate for this mom. We still want to use a low tidal volume strategy, particularly if we're worried about aspiration, ARDS, those sorts of things. So we're going to use a lower tidal volume in pregnant moms, probably 6 mLs per kilo, ideal body weight, and again, based upon height. So we measure mom and we will set the tidal volume on the ventilator according to her height, not her measured weight. And we're going to use 6 mLs per kilo to try and protect mom's lungs. But if we're doing that, we got to use a higher rate. Now, most of the time, you know, with the vent settings that we use, mom's respiratory drive is going to kick in, and she naturally, we can set it at 12. She's probably going to breathe 24 to try and maintain that elevated CO2, unless we did something to take that away from her, like, you know, a huge bolus of propofol or something. Propofol wears off pretty quickly, but some of our sedatives and induction agents can last a little while. And certainly if we use a paralytic like rocuronium that sits around for 45 minutes, 45 to 60 minutes, we have to be mindful of this, and we have to set the ventilator appropriately accordingly. So good question, and we'll talk a little bit more about that with the ARDS. Nurse Jenna,
Yeah.
did you have a question or statement?
Does the whole PIP and plat thing change as like a little over in a season?
It does. It does. PIPs are going to be higher. So, so we're talking about ventilator pressures. And this is something that we watch on the ventilator to try to avoid barotrauma to mom's lungs. So we have a peak inspiratory pressure, and then we have a plateau pressure. So the peak inspiratory pressure is the pressure while the machine is delivering a breath, and the plateau pressure is the pressure after the breath has been delivered and just before mom exhales. And we can do a maneuver on the ventilator to measure that. But in general terms, that's what the PIP and the plateau are. So yes, both are going to be higher because of, you know, the gravid uterus and everything that's going on in the pelvis and abdomen pushing up on the diaphragm. I mean, it's, you know, it's not an abdominal compartment syndrome, but you can think about it similarly to where what's going on in the belly is going to have an impact on delivering that breath that you're telling the ventilator to deliver, and the amount of pressure it's going to require to deliver that breath. Does that answer your question?
Yes, sir.
Okay. A little bit about HELP syndrome. Obviously, you know, this is like, you know, medical emergency type stuff. You know, this comes with increased morbidity and mortality. And, you know, we need to recognize it, but we also have to recognize and distinguish it from some of the things that can mimic HELP syndrome. So other medical conditions that can cause low platelets and hemolysis, such as TTP, as we're going to talk. So this, you know, is technically a part of the spectrum of preeclampsia and eclampsia, but, you know, unfortunately, some of these patients, a minority of these patients, don't have hypotension. And as mentioned, there are other obstetrically related things like fatty liver pregnancy, or medical conditions like lupus or TTP or HUS that can mimic HELP syndrome. And again, the management's going to be very different. HELP syndrome, usually you deliver the baby. It's not going to do a thing for TTP or complications of lupus. So, you know, lab testing is obviously, as already alluded to, very important in making this diagnosis, and several complications can ensue as part of this syndrome. So prompt delivery is often necessary. TTP is more common during the 23rd and 24 weeks of gestation. Again, this is difficult to distinguish from HELP because here again, you've got low platelets in TTP, you've got hemolysis in TTP. But some hints are that the LDH will be significantly higher in TTP, and platelet counts tend to be lower in TTP than in HELP. TTP, the coags are usually normal, but that is not the case in HELP. And again, the management is different. So TTP, plasma exchange, calling the American Red Cross, calling me to put in the dialysis catheter, and the American Red Cross to do plasma exchange would be the treatment for TTP, as opposed to delivery and HELP syndrome. And TTP, you don't give platelets. You can give platelets in HELP, but you don't give platelets in TTP. As I was kind of taught in medical school, that's like putting gasoline on a fire by giving platelets. Rather, we have to treat the underlying cause of the thrombocytopenia with TTP. I'm not going to belabor this too much, but hemorrhage is not uncommon. It's a very common cause of patients to come to the ICU, particularly postpartum. And it's usually, or not uncommonly, related to abnormal placentation with, placenta accreta or increta or percreta, different depths of invasion of the placenta through the uterus, as kind of listed there. With associated, significant risk of bleeding and other complications from severe hemorrhage, such as DIC. And these patients often bleed and bleed a lot and need a large amount of resuscitation, and, not infrequently would be part of an MTP, massive transfusion protocol. And so we need to be prepared for that, and not infrequently, this is significant bleeding, and the patient's got to go back to the OR or go to the OR for a hysterectomy or something like this. So a number of different complications can ensue, including massive blood loss, giving them lots of blood. If we're doing a massive transfusion protocol, we're often giving blood. I think that's on the next slide, but we're giving bloods, we're giving platelets, we're giving FFP. The more blood products we get, the more risk of pulmonary edema, and the more risk of ARDS, particularly with our FFP. And so, lots of potential for complications with massive bleeding complicating, the pregnant patient in the ICU. And so, one of the biggest risk factor is a uterine scar, and not infrequently related to a prior C-section. Other risk factors include advanced maternal age, assisted reproductive therapy, multiparity, uterine surgery, and, pelvic irradiation, lots of different things that can put moms at risk for abnormal placentation. Oftentimes, hopefully we know about this, we find this prior to planned delivery, because oftentimes mom's going to be delivered early and in a very controlled manner in a very experienced center. And hopefully we here at Jenny can avoid any complications from that. But sometimes patients show up at our door in labor and we don't know what's in there, and chaos can ensue. As mentioned, large volumes of blood are not uncommon in these situations, and I guess I already talked about massive transfusion protocol. Kind of interestingly, we had trauma last week, and we talked about trauma and massive transfusion protocol and a 1-to-1-to-1 approach. The OB data apparently recommends a 2-to-1-to-1, so 2 RBCs for every platelet and FFP. And I'm sure there's things that kind of factor into that. But nonetheless, these patients, can certainly bleed and have lots of complications for us to be mindful of. Amniotic fluid embolism, I hope not to see. This is a rare complication, but as we'll see on the next slide, associated with a very high mortality risk. This is thought to involve inflammatory anaphylactoid response to fetal antigens in mom's circulating vasculature, ultimately leading to the profound shock and cardiopulmonary complications that ensues after this. The triad, these patients have pulmonary and or systemic drop in resistance, decreased LV function, profound changes in coagulopathy, developing DIC, and often resulting in respiratory failure, cardiogenic shock, and cardiopulmonary arrest. So these patients get real sick, real quick, and unfortunately, this is supportive care. There's no, antidote for this. There's no cure for this. It's just best supportive care. And as mentioned, this can come with a very high mortality, upwards of 60%. And if a patient has a cardiac arrest as a complication of this, it's reported over a 90% mortality. So I'm 15 years in, I got about 20 to go, and I'm hoping not to see this one in my ICU. We're about done with this portion of the talk. Rounding things out, tocolytic pulmonary edema, is a thing. Tocolytics are sometimes necessary to buy some time, upwards of about 48 hours or so. The tocolytics can lead to pulmonary edema, with magnesium sulfate and terbutaline being those that are commonly used. And, we've got the tocolytics on board, and then we've also got this increased cardiac output and expanded blood volume and increased heart rate and a decreased colloid osmotic pressure. So albumin's low, and other, osmotically active things in the blood are low. And so moms third space a lot of fluid, particularly while they're receiving tocolytics. And this all can lead to pulmonary edema and is something we need to be mindful of. More fluid certainly isn't going to help. It's going to harm things. And so we need to be fluid restrictive. If we can, in coordination with our OB partner, try to stop the tocolytic. Oxygen support's important. Aggressive respiratory support is important. Careful diuresis. This might be a circumstance that may be rapidly reversible, so we might think about using non-invasive ventilation. But again, we have to be mindful that these patients are at high risk of aspiration, and now we put an NIV mask on that's adding positive pressure. And while that may improve the oxygenation, it may put mom at risk for aspiration. So we need to be mindful of that. The last two slides here, I think, ovarian hyperstimulation syndrome. As kind of already described, this is, the supraphysiologic stimulation of the ovaries to induce ovulation to facilitate pregnancy, harvest the eggs, or for IVF. But unfortunately, this ovarian hyperstimulation can occur or even worsen during pregnancy, leading to a number of different electrolyte abnormalities, capillary leak and third spacing of fluid, and then hemoconcentration as well, which can lead to clots and strokes and other complications that we want to avoid but need to be mindful of. And then the last slide, and I'm going to make this real quick, I've alluded to fetal surgeries that are undertaken, and there are some obvious downstream complications that can ensue landing mom in the ICU that we need to be mindful of, and not infrequently mom needs some blood. This can induce preterm labor or premature rupture of membranes, lead to infections like chorioamnionitis, can lead to placental abnormalities like placental abruption, increased risk for clots, and so lots of downstream things that can be impacted by this seemingly, simple surgery on our baby. So that would be the whirlwind. That lasted longer than I would have thought. I'm sorry, but a lot of good discussion along the way. Dr. Lang, I really appreciate everything you had to add. All right, so we're going to talk about ARDS a fair amount. We're going to talk about good old sepsis. We're going to talk about identifying DVTs and clots and the differences both in the testing and the treatment of patients with clots. We'll talk a little bit about neurologic emergencies, somewhat ironically, I guess. And then talk about some of the hyperdynamic circulatory changes of pregnancy and how this complicates valvular abnormalities and particularly pulmonary hypertension, and why, while I'm very sensitive to moms wanting to, to women wanting to be moms, there are some underlying conditions that it's just not recommended. And we'll talk a little bit about that at the very end of the talk. All right, so we've talked about physiologic changes and how this can impact, a normal woman. But this can lead to critical illness and impact maternal and fetal outcomes. And other things occur. We talked about altered drug metabolism. We talked about increased oxygen demand. We talked about less oxygen reserve. We talked about physiologic respiratory alkalosis. And we already talked a little bit about the altered hemodynamics that occur as part of pregnancy as well. So in terms of respiratory conditions, naturally, I had to put this first, being the pulmonologist that I am. But ARDS, unfortunately, is not uncommon in pregnancy. And it's reported that it's 10 times more common in pregnancy. And it has to do with this two-hit model, where pregnancy is basically an inflammatory state. I mean, that's part of why there's a leukocytosis. There's always underlying low-level inflammation from this alien parasite in mom's uterus that's causing some low-level inflammation. Did you pick up on that? I'm throwing out some jokes trying to keep you. Yeah.
I'm just ignoring you.
Okay, all right. Thanks. But nonetheless, there's low-level inflammation and then a second hit, so aspiration. And with that second hit in the setting of some already present inflammation, ARDS is more likely to occur. The pathophysiology here, some sort of inflammatory condition leads to alveolar damage and impaired gas exchange. Part of the diagnostic criteria looks at the PF ratio. So this is the measured PaO2 in a blood gas divided by the delivered FiO2 by the ventilator or the nasal cannula or whatever. And so the lower the PF ratio, the sicker the patient is, the poorer the gas exchange is, and the worse the ARDS is, as I'll show you on the next slide. And then part of the diagnostic criteria is to have lung infiltrates, which are usually bilateral on the chest x-ray. I snuck this in there. This is the Berlin criteria for the diagnosis and prognostication of ARDS. So usually ARDS occurs within 7 days of some sort of precipitant, like an aspiration event or severe sepsis, or some other overdose or other event that led to inflammation and ultimately triggered ARDS with the bilateral opacities being present. And we more or less have to rule out heart failure or volume overload. Previously, that would be done with a SWAN. That was 30 years ago. Or with an echo, but basically it's us looking at the patient. Now, this is bilateral lung infiltrates, low PF ratio, and we don't think that this is pulmonary edema. And there was an insult present that led to or triggered this non-cardiogenic pulmonary edema of ARDS. As alluded to here, the lower the PF ratio, the worse the oxygenation, and the higher mortality. And you can see here, 45% mortality. Even in 2024, ARDS comes with like a 40 to 45% mortality because there's just no great cure. It's best supportive care, and some of these patients don't do real well. In terms of causes in the ICU, there's a nice kind of list of causes in pregnancy or in the immediate, post-delivery time frame here, with aspiration, being again a common one. But there's a number of different things. I'm not going to read this to you, but things unique to pregnancy or things not unique to pregnancy in a pregnant mom that can ultimately trigger ARDS, and there's your list. In terms of ventilator management, we already kind of talked about this, but I'll just reiterate. We often use a low tidal volume strategy, period, but particularly in ARDS, we want to use 6 mLs per kilo or lower tidal volumes in these patients. Again, in a pregnant mom, we're going to target a higher PaO2. We already talked about the CO2 normal being around 30. So permissive hypercapnia, which is a normal strategy in ARDS, not so much in pregnant moms, because that CO2 can decrease uterine blood flow, increase fetal intracranial pressure, leading to lots of stress on baby, and not an approach, unfortunately, that we can take. We will often prone patients with ARDS, but obviously advanced pregnancy can complicate or make proning nearly impossible. We have to be very careful with positioning. Patients with ARDS are on the ventilator longer, and certainly the case in pregnancy as well. So we need to be very thoughtful as we're positioning and repositioning mom to avoid bed sores, that we're not causing vena cava compression. And not infrequently, ARDS is a complication of an obstetric cause, and this can be an indication for early delivery of baby. I alluded to the fact that clots are more common in pregnancy. It's thought that they are 5 to 7 times more common in pregnancy than in age-matched non-pregnant women because of increased hypercoagulability and just stasis. So if you got a big gravid uterus kind of compressing venous structures in the pelvis, that leads to stasis, and that then can lead to clots. Obviously, previous clots are an increased risk, immobility is an increased risk, and obesity is an independent risk factor for developing DVTs as well. Here, it's the same approach. Compression ultrasound would be the way that we can diagnose a DVT. Anticoagulation is a little bit novel in pregnancy, though, and I've got a couple of slides on this. Low molecular weight heparin is the way to go. So almost all pregnant moms get Lovenox, get low molecular weight heparin in the hospital or out of the hospital during their pregnancy, as we will talk about. And DVTs classically we treat for 3 months, but if it's found early in pregnancy, the more pregnant mom gets, the less mobile she is, bigger the uterus is, more stasis, and it's probable. We would talk to our OB, but it's probable that they need a longer duration of anticoagulation. PE, same hypercoagulability and immobilization, and kind of the same risk factors. Diagnosis is a little bit different, though. We're used to doing CTAs on everybody to diagnose a PE, but the radiation can be detrimental to baby. Certainly in years to come, with radiation increasing risk of malignancies and lymphomas and these sorts of things. So we have to be mindful of that. Doesn't mean we can't do it, but it's a risk-benefit ratio. We often would start with the VQ scan first, and then depending upon the results of the VQ scan and our pretest probability of the likelihood of this being a clot, we would kind of decide on testing from there. Again, low molecular weight heparin, but some of these patients are pretty sick. We see PE patients not infrequently with some right heart strain. I think in this setting, we probably would change our risk-benefit ratio just a little bit and try to avoid giving thrombolytics in just a little bit of right heart strain. But if mom's in shock, we give TPA. And yes, there's a little bit of increased risk to mom and baby of bleeding, but we've got to, save mom's life. And so we're going to give TPA in this setting, much like we could in an acute ischemic stroke, where you can give TPA, but we just have to be mindful and thoughtful about it. In terms, there's kind of a nice table here that is probably beyond us, but this is something that I think an OB managing a mom who needs anticoagulation may utilize, because there's a lot of different situations where moms require anticoagulation. Warfarin is teratogenic. It is damaging to babies. So, you know, once a mom's pregnant, we got to stop the warfarin and we got to come up with another option. And more times than not, that option is going to be low molecular weight heparin. I was looking today to kind of remind myself, and, you know, DOACs, things like Eliquis can be used in pregnancy, but there's much larger body of evidence in support of low molecular weight heparin. I kind of wish Dr. Lang was on to give her opinion and whether or not she ever uses the DOACs during pregnancy for, you know, AFib or whatever. But nonetheless, low molecular weight heparin is going to be utilized most of the time. Warfarin cannot be used, and you know, DOACs, direct oral anticoagulants like Eliquis or Xarelto, maybe. You know, the pregnancy category is like C, so basically meaning we don't have enough data, but nonetheless. All right, so moving on, sepsis, also very common, fourth most common cause of death during pregnancy. And I already kind of mentioned genital tract infections are the vast majority of them. More than 50% of the infection that lands a patient in the ICU is related to the genital tract, whether that's a UTI, whether that is pyelonephritis, community-acquired pneumonia is more common in pregnancy as well. More times than not, we can use the same antibiotics, but there are some antibiotics like fluoroquinolones that we can't use in pregnant moms because they too are teratogenic and potentially damaging to baby. And so we have to be thoughtful about the fact that mom's pregnant and what antibiotic are we going to use. And sometimes, you know, mom is septic and we give antibiotics and we think it's a genital tract infection and they're not getting better. And, you know, much like some other intra-abdominal infections, we have to be thoughtful of, is there a source of infection that needs to be surgically removed? And so retained products of conception or any foreign body in the pelvis may be that source of infection and may be the reason why mom is not recovering with said antibiotics. This would be a kind of a comprehensive list of genital ureteral tract infections and predisposing factors that can lead to this infection. And then on the right, the types of bugs associated with those infections that we have to be thoughtful of when we are choosing our antibiotics. And this is pretty specific, so we're not going to get into too much depth about this. Amnionitis happens, you know, in pregnancy. We don't see this very much, but you do. And we need to be thoughtful about this. If mom has a fever, mom's tachycardic, baby's tachycardic, and there's a lot of uterine tenderness that would be a sign of this potential infection. We need pretty aggressive antibiotics because this is putting mom at risk of sepsis and septic shock, and this is putting mom and baby at risk for preterm labor. So we need to be aggressive in treating that. Toxic shock syndrome, we see it in the ICU. We unfortunately had one in the summer that didn't go so well. This is a very significant infection. This is more common in pregnancy and needs to be recognized as not only, you know, sepsis, but toxic shock syndrome with appropriate antibiotics, including clindamycin, because that binds the toxin that is driving the shock. So if we suspect toxic shock syndrome, we got to start clindamycin early. IVIG improves outcomes of this infection as well, and that too needs to be started early. And then good aggressive supportive care, because this can be a very significant infection and complication of infection that can come with an associated mortality. Polymicrobial infections are more common. Yes, Nurse Jenna.
Dr. Krychek. I probably should know this, but what's IVIG?
So IVIG, it's an immunoglobulin. So we're giving patients immunoglobulin, and it's dosed like once or twice daily, 3 to 5 days or something like that. But it helps to treat the inflammation and part of toxic shock. So it's an adjunct. It's a little bit controversial, I'll be honest with you. It is. Our recent patient with toxic shock, I wanted to start IVIG. I called our ID doc, I was like, I don't think so. And then he called me back 30 minutes later and was like, yeah, we should start IVIG. So there's a little bit of controversy that comes with it. It has a number of different indications, really not that many, which is the question, but this is one that I think there's enough evidence and support. When I see, toxic shock syndrome, I think IVIG, which is why I asked the question. So, good question. As mentioned, polymicrobial infections. Many of these patients, again, have genital ureteral type of infections, and that's an area with gram negatives, but also anaerobes. And so polymicrobial infections are more common, and we need to use more broad spectrum antibiotics to treat these patients. We're moving along, I promise. We're almost done. Cardiovascular disorders. Again, pretty common in the ICU. It's stated maybe 18% of ICU admissions and upwards of over a third of maternal deaths occur because of cardiovascular complications of pregnancy. And again, this primarily has to do with mom's underlying cardiovascular condition, which gets complicated by all those physiologic changes that we've talked about a few times, so I'm not going to report all of this. So the WHO actually looks at the different underlying cardiac conditions and puts them into 4 different pregnancy risk classes. Class 3, so 1 and 2, probably okay, just need to be cautious and monitor mom carefully. Class 3 indicates increased risk of mortality or severe morbidity. So here we're going to have a really heightened awareness. And then class 4 is where pregnancy is basically contraindicated because of the very high risk of mortality or morbidity. And so we're going to talk about some of these, but like pulmonary hypertension or, really significant cardiomyopathy with an EF below 30%, mitral or aortic stenosis. These are the things that are in class 4 that put moms at really significant risk of complications of pregnancy, so much so that we should counsel against pregnancy. But again, I want to be very respectful here of, mom and mom's choice to, woman and woman's choice to want to be a mom. And, we want to be supportive and we want to try and help get them through their pregnancy, but boy, it comes with very significant risk. And we'll talk about some of these. So mitral stenosis, we don't see that much in this country. It's relatively rare, but moms with mitral stenosis, this gets significantly complicated with all those hemodynamic changes. And so, this not infrequently, leads to tachycardia, which can lead to atrial fibrillation because, atrial stretch is very common with mitral stenosis, and then you flood the vasculature with more volume and more atrial stretch, and moms go into AFib, and mitral stenosis does not tolerate AFib very well. So we want to be, mindful of all of that, and these patients are at very high risk of pulmonary edema as well. And, if pregnancy occurs and mom's got severe mitral stenosis, this may require balloon valvuloplasty, which we don't do very often, but that then will at least buy some time to help mom get through pregnancy and perhaps a early delivery with an okay outcome with mom and baby. But we've got to watch baby very closely throughout pregnancy and then certainly as we're approaching delivery for any complications of the hemodynamic changes that can come about with mitral stenosis. Pulmonary hypertension. I hate pulmonary hypertension, period. But pulmonary hypertension in pregnancy, I want no part of. So, most moms that end up going on drugs for pulmonary hypertension have to sign a form saying that they'll take 2 forms of contraception to avoid pregnancy, because the drugs are teratogenic, terribly so, and the mortality associated with pregnancy and pulmonary hypertension is listed here. Upwards of 1/3 of women with pulmonary hypertension who get pregnant may die as a complication of the hemodynamic changes with pregnancy. So, this really, unfortunately, kind of needs to be avoided. And again, I'm not sure how much I'm happy with my asthma, so I'll stick with my asthma. But nonetheless, this can lead to progression of their disease because of the hypercoagulability and microthrombi that can occur in those smaller pulmonary arteries and capillaries. And so they get disease progression leading to right ventricular failure. They can have overt pulmonary thrombosis because they're hypercoagulable. Their anticoagulation is complicated, as we've already talked about. So really complex situation here. Supportive care with oxygen and diuresis to offload the right heart, and really aggressive meds like IV prostanoids and anticoagulation are necessary. And most importantly, expert consultation, because this is something where an expert center is managing these patients as best as possible, knowing the significant complications that can ensue. Briefly, aortic stenosis can lead to heart failure and fatal arrhythmias. And, mechanical valves are complicated in pregnancy. Again, you've got this mechanical valve that's already increasing your risk of a clot. Then you're hypercoagulable with pregnancy as changes in physiology. And then your anticoagulation gets complicated, and you end up on low molecular weight heparin, but perhaps it's being underdosed as you're putting on some weight, and we know that low molecular weight heparin is weight-based, and then boom, you get, you clot off your prosthetic valve. That could be a life-threatening situation. So that's something that needs to be monitored or counseled against pretty carefully. I had never heard of this mnemonic, and I don't really like mnemonics, but this is one recommended by the American Heart Association for common causes of cardiopulmonary arrest in pregnancy. And we've talked about a lot of these. We've talked about bleeding complications, embolisms, anesthetic complications. We didn't talk specifically about an atonic uterus and bleeding complications that come up with that, but it happens enough that it made the U of Bow. C is cardiac disease, H is hypertensive disease, O is, well, of course, other, like hyperkalemia and, electrolyte abnormalities, and the H's and the T's and the things we commonly think of that aren't directly related to pregnancy. P is placenta, and S is sepsis, and that makes up Bow Chops as a mnemonic for us all to be thoughtful of in our next code or medical emergency on the 5th floor. Other things, just kind of some pearls here with regards to management of pregnant mom with cardiopulmonary arrest. Keep in mind CPR a little higher on the sternum is necessary, particularly in more advanced pregnancy. And mom's gravid uterus sitting right below the sternum, and if we go too low, we're not getting good compression or not getting good chest compression. Be mindful of lateral displacement of the uterus during CPR to try to optimize blood delivery both to mom and to baby. If magnesium toxicity is thought to be the driver, calcium gluconate may be an antidote to help treat and restore cardiopulmonary circulation. And this is hard to think about and talk about, but beyond 20 weeks gestational age, if the code's not going so well, we have to be thoughtful early about a peri-mortem C-section to try and save baby's life, recognizing there's probably a pretty good chance we're not going to get mom back. Neurologic problems to round things out. We've already talked about seizures related to eclampsia, But keep in mind, pregnant moms are at risk of intracerebral hemorrhage that can lead to seizures, so we need to be mindful of that. And then, some moms just have epilepsy. And later on in pregnancy, due to altered pharmacodynamics of their anti-epileptic, they're not getting adequate coverage with their anti-epileptic. And so we need to be thoughtful about that. If a mom with epilepsy comes in seizing, it just may be that they're undertreated. NAC sulfate, of course, treatment for eclampsia, pre-treatment to avoid, and treatment when it happens. And then, there's a variety of anti-epileptics, as we've kind of already talked about. Altered mental status and visual symptoms, not uncommon. As I was reading about this and, the neurologic emergencies, apparently agitation in pregnancy is a warning sign. Having had 5 children, I thought agitation was a normal physiologic change of pregnancy, but apparently it's a warning sign. I jest, and just trying to wake you up. But anyway, we do need to be thoughtful of acute agitation as, potentially an altered mental status or, a part of one of these syndromes, like PRESS. Are you guys familiar with posterior reversible encephalopathy syndrome? So this is a complication of pregnancy, pregnancy or otherwise. Let me say this differently. It's a complication of hypertension in general. So, this would be something that we would see in the ICU in a pregnant or non-pregnant patient who is hypertensive and they're encephalopathic, and we scan their head with a CT and there's no bleed, and yet they're very altered and we can't figure out why, and their electrolytes are fine and there's no other medical cause. While this is somewhat of a diagnosis of exclusion, there can be some abnormalities on an MRI. So certain distribution of MRI abnormality that would lead to a diagnosis of PRESS. And really the management is just controlling the blood pressure, and in time with some changes in the circulation, the patient wakes up. But this happens in pregnancy and is associated with.
I wonder if she had PRESS. It wasn't a stroke, maybe that's PRESS.
Maybe it's just PRESS, I don't know, we'll see. Here again, think about intracranial hemorrhage as a cause for altered mental status. Obviously we need to scan these patients. Head CTs are fine. We may have to shield the abdomen for head CTs. CT contrast is okay in pregnancy. Gadolinium, on the other hand, can be associated with some toxicity. So we have to kind of talk to our OB, talk to our radiologist. Do we really need gadolinium if we're getting an MRI in our patient? Strokes, pretty common, unfortunately. We are just being made aware of this. This can lead to upwards of 20% of deaths in pregnancy. Ischemic strokes are more common than intracranial hemorrhages, are more common than subarachnoid hemorrhages, and more common than venous sinus thrombosis. We don't see that very often. That only happens in patients who are hypercoagulable, that they would develop venous sinus thrombosis. And that's a tough one to diagnose, and it's a tougher one to treat because they're bleeding, but they have clot, and we actually need to give them heparin, and then they bleed a little bit more. But anyway, that happens, but not all that common. Does happen in pregnancy. I've seen this in weightlifters using testosterone and things like this. But anyway, that is sort of the order of complications in strokes. We talked about the hypercoagulable state, hypertension, and, preeclampsia putting pregnant moms at risk of strokes. Again, we can give thrombolytics if they're candidates, if they're eligible. Really, pregnancy doesn't change that much at all because obviously we want to avoid the complications of an acute stroke if we can intervene early with thrombolytics in an ischemic stroke. And then secondary prevention obviously is necessary as well.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.